Hi, and welcome to this important update regarding the early warning score, also known as USE, for early detection of the deteriorating patient. Unplanned ICU admissions are considered a serious safety event. In a retrospective observational study, it was discovered that up to 94% of unplanned ICU admissions displayed changes in vital signs within 48 hours of transfer. Almost half of those cases, there were delays in recognizing and acting upon these abnormal vitals. Trends like this can lead to poor long-term survival rates, especially in the older populations that we serve. Whether it's hospital-acquired or natural disease progressions, complications are inevitable and represent a huge burden on patients, providers, and healthcare systems. Missing the opportunity to rescue patients from decline is a major safety issue and is highly sensitive to the quality of care. Understanding when and where these failures occur is essential for nurses to lessen any risk while the patient is under our care. The 3 R's of failure to rescue of an unwell patient can be divided into 3 critical stages: failure to recognize the signs and symptoms of complications, failure to relay important information regarding complications, and failure to react in a timely manner and appropriate manner to a patient's deteriorating condition. Each of these stages represents several opportunities to improve patient safety. Nurses and providers play a vital role in recognizing signs and symptoms of evolving complications. The most common root cause was failures in the monitoring of patients who was clinically deteriorating. There is a significant amount of literature that supports the use of early warning score tools, EHR triggers, checklists, and proactive rapid response team rounding to improve recognition. The early warning score is a form of track and trigger tool used to detect potential deterioration and provide intervention bundles and an escalation plan. There are many versions used across the world and is endorsed as best practice for early recognition for at-risk patients. It helps to identify deteriorating patients by quantifying abnormal vitals as well as other indicators of organ dysfunction. The composite score is used to classify the severity of patients' current hemodynamic situation. It's to be performed immediately after taking a full set of vitals and should be assessed frequently throughout each shift. It is not necessary to perform early warning score on comfort care DNR patients. In the interest of patient safety, Baptist Healthcare will implement this patient monitoring model system-wide to all acute care units to include OB. This model was adopted by our Mayo Clinic partners to reduce failure to rescue rates. In this pathway, you will see that a full set of vital signs and early warning score will be assessed and documented every 4 hours. Note that if a patient has abnormal vitals or an elevated U score, we must repeat and document a full set of vitals and early warning score within 30 minutes. This gives us a half an hour to investigate what could be causing this abnormal. In most acute care units, vitals are typically delegated to the patient care techs who will notify the nurse of any abnormal. It is extremely important that although we trust the techs to perform this duty well, nurses must verify because we are ultimately responsible to follow up and respond timely. After calculating the patient's U score, you will move to the U's interventions. U scores greater than or equal to 2 could be expected in some patients. For example, the post-op trauma patient fall from height status post femur fixation with several rib fractures might have a respiratory rate of 21, SATs of 91, might have a low-grade temp. You would want to go to the room and physically examine the patient, encourage cough, deep breathing, manage their pain, screen for sepsis, review previous vital signs and labs, for example, and then recheck a full set of vital signs and U score within 30 minutes to assess the effectiveness of your interventions and the need to intervene further. It is very important that your 30-minute repeat of full set of vitals is documented in the medical record. Charge nurses are to be notified if there is no improvement in vitals or early warning score after 30 minutes. Note that any parameter with a single score of 3 requires immediate provider notification. If the provider is unable to respond to the bedside, a rapid response activation should be seriously considered. With a U's greater than or equal to 4, the nurse should involve the charge nurse. At this point, the patient is obviously attempting to compensate, whether it's from potential fluid or blood loss, infection, respiratory or heart failure, Action needs to be taken promptly to avoid potential harm. For U's greater than or equal to 6, the nurse must act emergently or risk further decline. A patient with this high of U score should be monitored at a higher level of care. When assessing your patient's condition, it is important to screen for other risk. Sepsis happens to be a common pathway for many diseases and could be community-acquired or hospital-acquired, and we must always include it in our differentials. On your unit, you will find a sepsis screening tool. This tool is used by nursing to evaluate patients who meet criteria for severe sepsis and require a sepsis workup. It also has a section for you to fill in the sepsis bundle times to ensure our sepsis patients receive the best possible outcomes. This form can stay with the patient's physical chart and be sent to medical records after patient's discharge. The form is not a permanent part of the patient's record and will be sent to the sepsis quality team. So let's summarize some key points in early recognition of the deteriorating patient. Using a supplemental track and trigger tool such as the U's is best practice to reduce failure to rescues if assessed accurately and with each vital sign assessment. All patients on the acute care units, to include OB, will have vital signs and U's assessed and documented every 4 hours. You must have an explicit order from the attending provider if frequency of vital signs and U's is to be decreased, or you may defer if the patient is DNR comfort care only. Interventions must be documented for all U's greater than or equal to 2, and all inpatients are to be screened for sepsis every shift. For questions or feedback regarding this early warning score tool, please contact Nova Francis, Clinical Intervention APRN. I can also be found on Telmedic. Thank you.